Hello, PsychU community, and welcome to today's webinar, The Role of Nurses in Reducing Stigma Associated with Mental Health Conditions. Thank you for joining us today. I'm Roland Larkin, a medical science liaison for OPDC. I will be moderating the presentation today, and we're in the month of May, so I should note that May is Mental Health Month, time of year in which the importance for caring for the way we think and feel is acknowledged and promoted in society, though there's still much to do to combat the stigma connected with mental health conditions. Today is also the last day of National Nurses Week and the 200th birthday of nurse pioneer Florence Nightingale, an extremely gifted scientist, statistician, and teacher, a fierce advocate for quality patient care, and a person who's left indelible marks on the fields of nursing, medicine, and public health. And I think it's fair to say that her legacy lives on in the two talented nurse clinicians I'm about to introduce, Tony Amberg and Hannah Phillips-Hall.
All right, so let's just take a quick look at the data here. So we think we've come a long way, but of course, all of us in psych know how far we haven't come. A survey of over 500,000 US adults found as recently as 2016, 30% of respondents reported that their perception of stigma explained their unmet mental health needs. So actually, that's interesting that it was less in this survey than what you are seeing. But of course, we have a sample bias, don't we? We see the patients who are having trouble getting their needs met. So what were the kinds of things that held them back? Concern about neighbors, job being negatively affected, confidentiality concerns, and then of course, the one we all encounter, fear of medication, and certainly fear of being involuntarily committed. So stigma with mental health conditions, as we all know, is a multifaceted issue. Certainly there is the stigma in the public, although this has improved tremendously. I think we can all agree that depression is no longer the taboo that we've talked about in many sectors of society. Of course, there are certain cultures and sectors where still psychiatric illness doesn't exist. And all kinds of other things go on. And then we have other stuff, don't we, Hannah?
Yes, for example, with self-stigma, I tend to view that as the stigma that the individual is imparting upon themselves, where maybe it could result in a lack of wanting to try anymore. You know, I already have this diagnosis, it's kind of, I'm done for, or they might not necessarily reach out to their loved ones, family, and friends because of that self-imposed stigma.
Exactly. And structural stigma we're all familiar with.
I think the structural stigma too, that tends to have a little bit of a ripple effect. For example, we know that sometimes our patients with an SMI or serious mental illness might end up getting arrested or incarcerated, which if they're then, labeled as being a felon, it makes it even more difficult to find permanent housing based on the requirements of the complex or housing development.
Well, and didn't you just hit the nail on the head? Isn't it shameful that according to Cook County Sheriff Tom Dart, the largest mental hospitals in 44 of America's largest cities are the jails? That just says it all. And then, of course, there's the issue of insurance and the fact that we still have so much problem getting coverage and so much problem getting medication for people when we know it works, when we know it would keep them out of the hospital. And it's such a struggle. So absolutely.
So to tie into this a little bit more, we know that the amount of stigma an individual receives can vary based on their diagnosed mental health condition. For example, we know that individuals with substance use conditions, such as alcohol use disorder in this one study, were perceived to be more responsible for their mental illness versus somebody without a substance use condition. And that definitely speaks to the variety in how we view people that way. We also know that patients and individuals in another study said that they had a greater desire for social distance from individuals with schizophrenia versus those individuals with depression, as Tony had mentioned previously. Not to say depression has become normalized in our society, but it has definitely become more socially acceptable to speak about openly versus something like a psychotic disorder. We also know that these individuals are perceived as being more dangerous than somebody who perhaps has just depression, not to minimize depression in any way, shape, or form.
And isn't that something? I mean, I know that my students are always surprised when I tell them that people with psychosis are more likely to be victims of crimes than they are to be the committers of crimes. And certainly, you know, most of what puts people in jail are things directly related to their mental illness. I mean, if you've got a paranoia and somebody in a uniform is coming up to you screaming at you at a bullhorn, you're going to run. And this is tragically how so many of these terrible things happen. Cultural and ethnic factors. So I used to work in Chicago at the hospital that was closest to Chinatown. And so from time to time, we would get patients in from that community. And there was just a complete aversion by the families we met to believe that there was such a thing as mental illness. And even if they did, there was the sense that is true in some cultures that the illness brings shame on the family. It's not something that needs to be dealt with in an individual. It's not something that could be cured and made better. It's a shame for the whole family. So perceptions of the illness, whether it is an illness at all, whether it should be treated, availability of support. And we should also note, by the way, that there are cultures where the availability of support for people with mental illness is actually very strong. There are cultures where people with schizophrenia are actually thought to be eccentric, interesting, perhaps hearing voices from God. Our culture is not the standard by which we should measure all cultures for how to treat people with mental illness. And then, of course, the issue of coping strategies. So one of the things that I think is really important in looking at these cultural factors is either under-pathologizing, where sometimes we see a symptom and we say, oh, that's just the way they behave in their culture, or over-pathologizing, thinking that the way somebody behaves is a symptom, not a symptom, a manifestation of their culture versus actually a manifestation of a psychiatric disorder. We should also note that in different cultures, people manifest psychiatric disorders in different ways. And that's very important to keep in mind.
To add a little bit to that, Tony, I know one of my biggest quandaries when I first became a prescriber early on in my career, I kept on looking up on the internet. How do I tell the difference between psychosis versus what is considered to be a cultural norm in some form of spirituality, be it, you know, witchcraft, whatever it might look like? And I have personally found that one of the best ways to tease that out is to involve the loved ones and caregivers and to ask them directly.
What a great idea.
So we also know that depending on the site where the patient receives care can impact the quality of that care. So we're seeing one interview by a psychiatric nurse that describes how honestly in the ED, they might not be as interested in helping that mental health patient as they might be in helping a patient with a possible stroke or heart attack or something of that nature, which while it does make sense kind of based on acuity, it also doesn't make sense because it's preventing that mental health patient from receiving the caliber and quality of care that they might necessitate. This really does only put a little bit further support for the importance of mental health ERs.